right, well, welcome everyone. Good morning. I want to welcome Dr. Arun Sundaram and our resident team of Seema and Sheikha this morning to talk on something that frankly is very topical and I think very, very interesting, and probably some information I'm probably glad I did not know before receiving my many vaccines, but we'll see how things go. So our host this morning is Dr. Arun Sundaram. He completed his clinical neuro-ophthalmology fellowship combined with a master's degree here at UofT under Dr. James Sharp, and he joined us as staff about 12 years ago. He's been at Sunnybrook since 2011 and also worked at Toronto Western Hospital from 2010 to 2017. Here at Sunnybrook, he focuses primarily on neuro-ophthalmology and also does some additional work in stroke. He was a co-supervisor for Dr. James Sharp's neuro-ophthalmology fellowship until his passing. So thank you very much, Arun, for leading us in rounds today, and I very, very much look forward to this interesting topic. Thank you.
Okay, good morning, everybody. My name is Seema. I'm one of the PGY4 residents, and this morning I'm really excited to be presenting alongside Dr. Sundaram and Sheikha to review a really interesting case that presented several months ago. So instead of starting our day off with a shot of espresso this morning, we're going to start off with a discussion of double vision. And before we jump into it, I'd just like to say that although we'll be discussing COVID-19 vaccines and their adverse events, we all know that COVID-19 vaccines have been proven around the world to reduce morbidity and mortality related to COVID-19 vaccination. And it's been well shown that in most people, the benefit of vaccination far outweighs the risks. However, due to the high rate of vaccinations taking place over the past year and likely for many years to come, it seems, it's really important for us to discuss the rare but significant complications that may come with these inoculations. So with that, let's meet our patient. So this patient is a 62-year-old male who was actually admitted initially at a community hospital in the GTA. He was a fairly healthy gentleman with a history of an idiopathic GI bleeds several years ago that had been treated with a colectomy and had been noted on and off to have some borderline hypertension, but had never required medications. Other than that, he had no other vasculopathic risk factors, including no diabetes, no dyslipidemia, and no heart disease. He was a smoker, though, about 20 cigarettes a day since the age of 23 and occasional alcohol. And he was referred to our service for a chief complaint of headache with diplopia. This all began when he received the first dose of his AstraZeneca vaccination in March of 2021. The next day, he developed a new onset severe headache, which was very out of the normal for him. These headaches persisted daily until about 10 days later, he also developed intermittent binocular horizontal diplopia that was worse in the distance and better at near. This diplopia came and went until about a week later, it became persistent. During this time, he was otherwise well with a negative review of symptoms, including no systemic fever, malaise, weight loss, or rash, and no other symptoms of giant cell arteritis. At this point, he presented to the hospital department near his home. And I'd like to ask the audience, if you were the emergency doctor reviewing this patient, which step would you choose next? An urgent CT of the head, an MRI brain, which we all know takes at the minimum about 2 weeks to get, an urgent lumbar puncture for CSF analysis and opening pressure? Would you obtain an urgent ESR CRP? Would you observe and simply follow up in an outpatient setting in 1 to 2 weeks? Or would you say that more information is needed at this time? So we'll give that just a moment to run.
We'll give that a moment there, Seema. But good disclaimer at the beginning. I think it's very necessary these days. So
yes, not part of any protests that may be happening right now.
All right, here we go.
Okay, so many people would go for an urgent ESR CRP, and the second most common topic is choice is an urgent CT head. And I think that these are both really reasonable options given this presentation. The emergency room physician in this case ordered a CT of the head. They did in fact order an ESR CRP as well as part of the admission. The CT head demonstrated microangiopathic disease, but otherwise nothing acute. So the patient was admitted to hospital for further investigation of his headache and diplopia. The MRI that was performed subsequently in his admission with angiography and venography again confirmed microangiopathic changes, but normal and normal vessel flow with no sign of sinus thrombosis, and there was no abnormality found in the cavernous sinus, cranial nerve, or course, or leptomeninges to explain his diplopia. As a result, he was then referred to neurology, and he was assessed by neurology as an inpatient at the beginning of April. The most striking finding from the neurologic exam was, first of all, it began with the pupil exam, which demonstrated equal and reactive pupils without an RAPD or an isochoria. However, strikingly, the patient had a left large angle esotropia in primary position, accompanied by a right ptosis with the eyelid margin at the level of the pupil. On extraocular motility testing, the right eye demonstrated an 80% limitation of abduction, so about a -3, and the left eye demonstrated about a 90% limitation of abduction, so about a -4 or so, and the remaining ductions were normal. The patient was diagnosed with a bilateral abducens nerve palsy, and further investigations continued. The patient was then reassessed by neurology approximately 1 week later. Similarly, the pupils remained normal with no sign of anisocoria or RAPD, and the left esotropia was about the same. However, the right ptosis had worsened and was now obscuring the entire pupil with the eyelid margin. The limitation of abduction persisted in both eyes. However, a new interval limitation in adduction was found in the right eye. The patient was now only able to move their right eye about 60% of normal in adduction, so about a -2. Again, infraduction and supraduction were intact in both eyes. So the diagnosis appeared to be evolving. There was now a persistent bilateral abducens nerve palsy and a new evolving partial right oculomotor nerve palsy. So whenever we're faced with a patient who's presenting with multiple cranial neuropathies, there are two different approaches that we must consider. The first is to localize the lesion, and we can think about this starting from more anterior to posterior, more distal to proximal. So starting at the orbital apex, the superior orbital fissure, the cavernous sinus, the subarachnoid space, and the brainstem. At the same time, we can think about different etiologies. So cranial polyneuropathies can result from compressive lesions as a result of inflammatory or autoimmune conditions, vascular problems such as stroke, vasculitis, aneurysms, fistulas, infectious processes, trauma, and as well, we must always think about neoplastic conditions, which can include primary or metastatic processes, infiltrative processes, leptomeningeal disease, or even paraneoplastic syndromes. So with this differential diagnosis in mind, our patient underwent multiple investigations during his admission. A lumbar puncture was performed on the first day of neurology assessment, which showed a mild lymphocytosis, as well as slightly elevated protein. The remainder of his investigations were normal. This included the CSF analysis with virology, cultures, and cytology, a complete metabolic panel with CBC, as well as a vasculopathy workup, including a HbA1c. An extensive autoimmune and infectious panel was conducted. He was tested for COVID-19 because this has also been shown to be associated with cranial nerve palsies, and this was negative. Finally, he also had testing for acetylcholine antibody receptor antibodies, thyroid receptor antibodies, and had a CT of the chest, abdomen, pelvis to rule out malignancy, as well as the screening for paraneoplastic antibodies. Again, all of these investigations were normal. Having received these investigations, the attending neurologist empirically started the patient on oral prednisone at 70 milligrams per day to cover inflammatory causes. With the addition of this medication, our patient dramatically improved. His headache resolved within 2 days, and his right ptosis rapidly resolved within 4 days. However, he continued to complain of binocular horizontal diplopia. When the neurologist reassessed him, a prednisone taper was initiated and a referral was made to the Neuro-Ophthalmology clinic. On presentation to our clinic approximately 2 weeks later, the patient confirmed that he had not had any relapse of his headaches. However, his binocular diplopia did persist. At this point, he was on our steroid taper of about 30 milligrams of prednisone per day. On our assessment, the vision was excellent in both eyes, and again, there was no anisocoria, abnormality in pupil reactivity, or RAPD. The intraocular examination, including the optic nerves, was normal. And his neurologic exam, which was conducted to look for speech abnormalities, facial asymmetry, all of those were normal, including power in the extremities, deep tendon reflexes, and gait. These pictures show a patient's extraocular motility abnormalities at the time of his follow-up or the time of his assessment in our clinic. As you can see, there is a large angle left esotropia that persists, and his abduction remains slightly limited in both eyes. In the right eye, there is about a 10% limitation of abduction and about a 75 to 80% limitation of abduction in the left eye. The rest of his eye movements were normal, and the ptosis that had been seen initially had now resolved. The patient was therefore advised to taper the prednisone until he was completely off, and a repeat MRI of the brain and orbits was ordered to make sure there had been no evolution of his symptoms, given that the initial MRI had been done prior to the onset of the partial third nerve palsy. The patient was then followed monthly, and you can see that at his visit in August and September, the esotropia progressively improved and his abduction deficits improved in both eyes. At the August visit, the repeat of the MRI brain was reviewed, which again was normal with no enhancement and no abnormal enhancement seen, with the exception of the chronic microangiopathic changes. At his most recent visit, which was just about 1 week ago, you can see that his extraocular motility abnormalities had resolved. So here you can see these orthophoric and primary position with full abduction in both eyes and intact supraduction, infraduction, and adduction as well. Again, the ptosis has not returned and the pupils are equal and reactive. So this kind of makes us think, what caused this gentleman's cranial polyneuropathy? Well, when it comes to temporal association, given the normal investigations he had, we must wonder about whether this was related to vaccines. And indeed, cranial polyneuropathies have been reported following all of the vaccines against COVID-19. And there have been several case reports in the literature over the past few months to demonstrate this. It's important to remember that COVID-19 vaccination remains a diagnosis of exclusion. So all of the other investigations that we discussed must still be considered. However, according to the reports in the literature, the typical onset of a cranial neuropathy following COVID-19 vaccination occurs within 1 to 21 days of vaccination. It's been reported with all of the vaccines available so far, including viral vector and mRNA vaccines. And there is some variability in the resolution of these cranial neuropathies. They may resolve spontaneously. The fastest that we found in the literature was about 1 week, but some have been found to persist for greater than 6 months. In the small number of cases that have been reported in the literature, some resolve without any intervention, but others have been treated with steroids to dampen what is a presumed inflammatory response or component. The pathologic mechanisms between cranial nerve palsies and the vaccines are poorly understood. However, 2 main mechanisms have been proposed. The first is that the vaccine may induce an inflammatory damage along the myelin sheath of the cranial nerves, or that there may be actually localized reduction of blood flow to the cranial nerve, causing a microvascular injury. In our case, there are several unique factors that made us want to share this with everybody. The first is that this is the first report we could find of a bilateral abducens nerve palsy in conjunction with a unilateral partial oculomotor nerve palsy. And this makes us think that this was due to involvement of the nerve fascicles, multifocal nerve fascicles. This was gradual onset within 1 week of AstraZeneca vaccination, which had not been demonstrated before in the literature. And it's really important to highlight that in this gentleman, although he was understandably nervous to get any further vaccinations, he had no adverse reactions following his second dose or booster dose, of which he received the Moderna vaccines. And again, in this case, no other etiology was identified for his cranial nerve palsy despite extensive investigations. So this association between vaccination and cranial nerve palsies is not new. The most commonly demonstrated cranial nerve palsy following vaccination is a Bell's palsy, which involves cranial nerve 7, the facial nerve. This tends to be self-limited following vaccination and has been demonstrated after many, many vaccines, including the annual flu immunization, as well as many childhood vaccines that we routinely give. And upon large scale studies, it's been proposed that this may not actually be vaccine related, but may just simply reflect the general incidence of Bell's palsy in the general population, meaning no clear causal relationship has been demonstrated. Other cranial neuropathies, including abducens nerve palsy, oculomotor palsy, and trochlear palsy, have been reported following influenza, DTaP, MMR, and other vaccines. And amongst these, abducens nerve palsy is certainly the most common. In most cases, an abducens nerve palsy is self-limited following vaccination, but especially in children, it can actually be recurrent. It's typically unilateral, however, and again, there is no clear evidence of causality, keeping in mind that these are fairly rare adverse outcomes after widely given vaccinations. In summary, we just wanted to highlight that cranial polyneuropathies require thorough investigation to rule out worrisome or reversible pathologies. However, if other etiologies have been ruled out and given a possible temporal correlation with COVID vaccinations, it's important to recognize this may be an adverse event following a COVID vaccination. Although these adverse events are rare, they must be recognized. And this has two important implications. The first is that that most countries track adverse events following vaccination. And the second is that this has wide implications for patient counseling and treatment. Despite all of this, as we mentioned, COVID-19 vaccination generally remains safe and highly recommended. In fact, some of the more common side effects after COVID-19 vaccination are quite mild, including tenderness, pain, and swelling at the injection site, as well as some mild fever, malaise, or headache following vaccine. Severe adverse events that we must all be aware of include anaphylaxis, thrombosis, Guillain-Barré syndrome, and myocarditis and pericarditis that have been reported very rarely following vaccines. And indeed, reports of death temporally associated with the COVID-19 vaccination remain incredibly rare. This is all-cause mortality, and it's about 11,000 reports of death following over 500 million doses administered in the US. So again, just to underscore that these adverse events are very rare. So thank you very much for your attention. And we just wanted to highlight again that despite his eventful first dose, our patient had both the second dose and his booster dose very recently and has been asymptomatic since. Thank you.
Great case, Seema. Thanks for sharing. There is a question here in the audience for you from Dr. Weisbrod. Given that the pupils were never involved, and his symptoms evolved slowly with strabismus and ptosis, have we ruled out myasthenia?
Sure. Excellent question, Dr. Weisbrod. A few things to talk about here. The way the double vision started and the non-fluctuating nature, it sounded more like not in keeping with myasthenia gravis. This patient had the serology at the time of admission to the hospital, and the acetylcholine receptor antibody was negative before the patient was referred to me. And it was despite the high dose of the prednisone that the patient had, at least for a couple of weeks before he saw me, there's only resolution of the ptosis, but there was significant abducens paresis bilaterally, which was not in keeping with it. But it's a very interesting question that you asked, because COVID-19 vaccine, there's been some reports of myasthenia gravis. An 81-year-old patient after, a couple of weeks after mRNA vaccine, he had, systemic symptoms of myasthenia gravis, and he became serology positive. So there's a case report of that. There's another patient that was in the mid-60s or 70s with known stable ocular myasthenia gravis. After the COVID vaccine, he ended up having a myasthenic crisis. There was worsening of myasthenia gravis. That patient needed hospitalization, intubation. So it's just an autoimmune condition that can be triggered. So in our case, it was not myasthenia gravis. In other words, it was ruled out. And I've seen this patient, over the last 6 months closely. And so far, I've not seen any signs of ocular myasthenia gravis on examination.
Great case, Seema, and very nicely presented. We've seen COVID vaccination affect various parts of the eye. Our group just published a case of a patient who had a graft limbal stem cell transplant, and shortly after their vaccination developed rejection.
Mm-hmm.
Although these are rare, and like you all, I'll put the disclaimer, I'm pro-vaccination, but we have seen episodes of, I've seen recurrent herpes simplex, I've seen flare-up of zoster, and it's been published in the literature about graft rejection, and I actually have seen a couple of these. Interesting, like your case, I've seen it after the first vaccine, not so much after the second. In fact, I've tracked some of these patients for their second vaccine or their booster, and I've not seen a recurrent flare-up as well. So interesting. And yes, the vaccination can affect various parts of the eye. We need to be cognizant about. Typically in the first few days afterwards, up to a month or a few weeks after, there's no diagnostic test to prove that, which makes it difficult. It's really by association that you make the presumed diagnosis.
Yes, thank you, Dr. Slomovic. Absolutely, there's no confirmatory testing in any of these cases, unfortunately. Simply by excluding other causes, and the temporal association is how you can arrive at the conclusion. But definitely, there's emerging literature about all the different ocular complications that have been seen following vaccination, and certainly with the cornea and a lot of the intraocular findings. Again, it's been demonstrated with all of the different vaccines, including the ones that are not available in Canada. Around the world, it's been shown. It's quite interesting.
Thanks. Excellent presentation. I just wanted to ask, what do we know about the incidence of these patients going on to develop other autoimmune diseases in the future, and what is done for patients with pre-existing autoimmune diseases who are looking to receive the vaccine? Do we know much about the recommendations there?
So most often these things are usually in the first few weeks after the vaccination. In terms of other autoimmune conditions, a lot of patients are already on immunosuppressive agents if they have to continue that, but the vaccine efficacy is going to be a little less when they get the vaccination while being on immunosuppressive drugs. If they had a flare-up, any flare-up is possible. I talked about myasthenia gravis. There are case reports of Graves' disease after vaccination. So depending on what it is, the patients may need immunosuppressive treatment. This is what we can do. And it's always nicer to have other autoimmune processes. There's a list of things Shekhar is going to talk about that could affect the eye and the brain. So when we come across any of a complication like that, it's nicer to just recognize it on time and treat it with steroids.
Next presentation, Seema. I just wanted to make one comment. So I think still, I'm just wondering about the diagnosis in this patient. So one, I'd be interested in knowing in the early exam here, were the reflexes intact, and did the patient have ataxia? Because Miller-Fisher syndrome is definitely something that could happen, and this seems to be the most likely diagnosis in your case. I'd also be interested if ophthalmology or neuro-ophthalmology saw this patient early when they presented, because myasthenia gravis has a very characteristic exam, and it would be very interesting to know if there are features on the exam. Also, your first poll question, I think I want to emphasize that in neuro-ophthalmology, you really need to examine the patient well and localize the disease. So you don't want to start ordering imaging and a whole battery of tests without exactly knowing what you're looking for and what the likely diagnosis is. So I'd be wondering if this patient had any features of Miller-Fisher syndrome.
Okay, so to answer the question, yeah, there are a couple of case reports of Miller-Fisher syndrome, and this patient was managed by a neurologist who's also a neuromuscular specialist who does EMGs. So Seema's presentation clearly stated when I examined the patient, the deep tendon reflexes were present. That's number one. Number two, in Guillain-Barré syndrome, we see something called as albuminocytological dissociation, which means there's increased protein in the CSF and no cells to support it. We had a reverse of that in this patient. The CSF WBC was 10, but the protein was only mildly elevated at 0.6, which was not high at all. And the doctor who examined the patient also treats myasthenia gravis, who does EMGs. So there were no signs of that. So it was very highly unlikely that this patient had Miller-Fisher syndrome. The classic, and the gait was also normal, which we have mentioned here. Patient never had gait disturbance. So all that he had was a headache and double vision. The classic triad of Miller-Fisher syndrome is ophthalmoplegia, gait ataxia and areflexia. He didn't have the other two, so he never fit the clinical picture of Miller-Fisher syndrome here at all. And the last thing, Miller-Fisher will not respond to steroids. Patients with Guillain-Barré syndrome will need IVIG. So that's how they respond, and the course is very protracted. A lot of these patients don't have these kind of headaches that this patient had.
Excellent discussion. Shall we move on to your presentation, Sheikha?
Perfect. And as she pulls that up, there's one question here from Wendy Hatch. We may not know the answer to this because the rates are so low of these incidents, but do you know the risk of occurrence in those who've had COVID compared to the risk of this happening after vaccination?
There are a lot more case reports of COVID directly causing cranial polyneuropathy as opposed to vaccine, but there's very little in the literature, so we don't know. SEMA showed 4 case reports. A couple of them are case series. So it's isolated, only a handful of case reports after COVID vaccination presenting with 6th nerve palsy or partial 3rd nerve palsies. So incidence is likely much higher directly to be caused by COVID vaccine. SEMA and I, we were discussing about this. A couple of hypotheses put there. This virus may be vaso-invasive. It may affect the endothelium and the blood vessels, causing direct damage to the cranial nerves. That's said to be one of, excuse me, hypothetical cause here. But no matter what, COVID directly could cause cranial polyneuropathy at a higher incidence as compared to the COVID vaccine, based on what we have in the literature right now.
Perfect. Thank you. So let's get to the second talk. Thank you, Sheikha.
Good morning. My name is Sheikha Mohammed. I'm one of the PGY2s here at University of Toronto, and I'll be discussing COVID vaccine-associated bilateral optic neuropathy. So again, just like Seema stated earlier, I want to give a disclaimer that the COVID vaccines have been proven to reduce morbidity and mortality, and that we believe in most people the benefits of COVID vaccines outweigh the risks. But due to the mega-scale COVID vaccinations during this pandemic, it is important for clinicians to be aware of the rare but potential vaccine-associated complications. So our patient presented as a 52-year-old non-obese female. She was previously healthy and was referred to us from an optometrist for a query optic disc edema in both eyes. It started on the 27th of June when she received her second shot of the Pfizer COVID vaccine. This was followed by a gradual onset of a headache, which worsened over a week. It was characterized as frontal and periorbital in location and about 7 to 8 out of 10 in intensity. A week later, she developed blurriness to her vision and then continued to describe periorbital pain. She emphasized no diplopia and no pulsatile tinnitus. There were no fever, no neck stiffness, no chills, rigors, or any symptoms of an upper respiratory tract infection. By the 14th of July, she was seen in the eye clinic. Her visual acuity was 20/25 in both eyes. Her anterior chamber was normal. Her IOPs were normal. She did have bilateral optic disc edema. Her fields were considered subtle with non-specific depression of the left eye. And therefore, with preservation of visual function, a papilledema/IIH were suspected, and she was sent back to the ER for urgent CT venogram of the head. So this is what her optic disc looked like. And there's the obvious circumferential optic disc edema in both eyes with peripapillary hemorrhages on the right as well. Her visual fields again show non-specific depression, very subtle, but mostly on the left eye. So in the ER, the CT venogram was normal. There was no evidence of thrombosis. At this point, neurology were consulted and an LP was performed. The CSF opening pressure was normal at 16. Leukocyte count was 16 with a lymphocytic pleocytosis. Her protein in the CSF was normal at 252 and glucose was 3.1. Herpes simplex and varicella CMV PCR were all negative. Bacterial and fungal cultures eventually came back negative as well, and her cytology was normal. Neurology at this point orders an MRI brain and orbits with gadolinium, which showed very subtle enhancement of the optic nerve sheath bilaterally in the intraorbital portion and minor enhancement of the bilateral optic nerve heads, but no other leptomeningeal enhancement and no radiological signs of IIH. She ends up seeing neuro-ophthalmology at Sunnybrook. In the interim, her headaches persisted. There was no changes to her visual symptoms. Her vision was 20/14 both eye. Again, she pinholes to 20/25, just like her initial presentation. Her pupils were 4. They were sluggish to light. There was no RAPD. AOMs were normal. And again, the fundus exam does show circumferential optic disc edema, and the peripapillary hemorrhages on the right as well. Neurological exam was normal, with speech power was normal in all extremities. Her neck was supple and the gait was normal. She weighed about 125 pounds. So this is what the OCT RNFL looked like at the time. There's obvious thickness of both eyes, with the right eye averaging at 300 and the left at 265. The ganglion cell complex shows thinning circumferentially on the left and almost circumferentially on the right, and it measured about 50 and 36. This is an axial T1 weighted image with GAD showing very faint enhancement of the optic nerve sheaths bilaterally. So overall, our impression at this point was bilateral optic disc edema. We did not consider this an IIH presentation as she was not obese. There were no radiological signs. She had normal CSF opening pressure, and there was evidence of lymphocytic pleocytosis, all of which do not meet the modified Dandy criteria. So the differential at this point was inflammatory optic neuropathy versus a post-vaccination optic neuropathy. Serological investigations, including ANA, ANCA, ACE, NMO, and anti-MOGs were all ordered. She was treated with 1 milligram per kg oral pred for 2 weeks. After we confirmed TB skin test negative, CSF AFB was still pending. This was followed by a 10 milligram daily taper. Upon her 2-week follow-up, her headache has completely resolved. Her vision improved to 90 to 95% of normal. She was 20/20 on exam in both eyes. Her pupils were equal and reactive. There was no RAPD. Her color vision was full. EOMs were full, and optic disc edema started to resolve. The remainder of the investigations, including cultures of the CSF, AFB, cytology, NMO, anti-MOG, and all other serological workup, ended up being negative. So the diagnosis at the time, given the strong temporal relationship between the onset of the headaches and the visual loss following the vaccine, and the negative workup favor a vaccine-associated bilateral optic neuropathy. This is what her OCT looked like at that 2-week follow-up, with reduction of the RNFL thickness to 159 in the right compared to 300 and 135 in the left compared to 265. At 2 months follow-up, she remained stable with no recurrences of her headaches. She was completely off steroids at this point. Her optic disc edema had resolved with preservation of her visual function. And an OCT did prove that her RNFL was 103 on the right and 99 on the left. So at this point, 4 weeks ago, she did raise a question about getting the booster vaccine. She did remain stable at the time. Her exam was normal. There was no recurrences of papilledema. She wanted to get the booster, but she was very concerned. It raised multiple questions during that interaction. Since she got the Pfizer vaccine the first time, if she gets the Moderna, does this mean it's less likely to recur? Can we treat with prednisone post-vaccine if the recurrence does happen? And if we do, will it change the vaccine efficacy? We did advocate for a booster at this point, and emphasize that this is not a contraindication to get the booster, but she wanted to actually see allergy and immunology and take their input as well. And so she was referred to allergy and immunology. So there are many theorized mechanisms for optic neuritis in the context of vaccines. The most common, it's actually the most common demyelinating condition to occur with vaccinations. It has been noted with hepatitis A and B vaccines, influenza, measles, pneumococcal, and HPV, rabies, and BCG vaccines. Many theorized mechanisms are out there. Some include molecular mimicry. Essentially viral proteins expressed after the mRNA translation have elicited an immune cross-reactivity with human tissue. In terms of the COVID vaccines, the active component of the adenovirus vaccine, which is the Johnson & Johnson vaccine, shows a specific B-cell response that targets the vector-based vaccine, and that response can trigger a dysregulated immunological process. In terms of the mRNA vaccines, the Pfizer and the Moderna, they use antibodies against the spike proteins, and the activated Th1 cells cross-react with proteins and antigens in the outer retinal layers, retinal pigment epithelial layers, and the large arteries, and can therefore result in complications as well. If we look at the case reports published out there on COVID vaccine and optic neuritis, there are many that can be found. Some describe optic neuropathy after COVID vaccinations. For example, this just talks about a 69-year-old female who had bilateral optic disc edema 16 days after the Pfizer second shot, which resolved completely with IV salmeterol. It also discusses a 33-year-old 2 days after the first AstraZeneca vaccine had left visual loss, left disc edema, and the MRI did show enhancement of the left optic nerve. Again, vision recovered with steroids. Another case series describes atypical optic neuritis after COVID vaccination in a 65-year-old 5 days after the Pfizer vaccine, develops headaches and vision loss in the right eye. The vision goes down to LP and there was 360-degree edema. MRI showed thickening and enhancement of the right optic nerve. And after 5 days of IV steroids, the vision does improve to 20/100. It also describes a 67-year-old male within hours after developing the second dose of the Moderna vaccine, had bilateral left more than right vision loss. Vision goes down to 20/40 and NLP. There was no disc edema, but the MRI did show left optic nerve enhancement. And after 5 days of IV steroids, vision improves to 20/20 with normal fields, but remains NLP in the left. More reports also state autoimmunity as well, including active thyroiditis and bilateral optic neuritis, both of which improve after steroids use. And another case report on optic neuritis after COVID vaccine in a 19-year-old after the first dose of the Johnson & Johnson develops a left amaurosis and RAPD papillitis. MRI confirms left optic nerve enhancement and swelling, and the immune panel is negative. She does have positive CSF oligoclonal bands, again is treated with IV steroids and recovers vision completely. And optic neuritis is not the only ocular manifestation seen post-COVID vaccine, and Dr. Slomovic alluded to some of them. This is a meta-analysis of 31 articles published on ocular manifestations after receiving COVID vaccine across 3 databases. And it does list a variety of complications, starting from eyelid swelling and eyelid purpuric lesions, down to corneal graft rejections, macular neuroretinopathy, retinal detachments, also describing acute zonal occult outer retinopathy, arteritic anterior ischemic optic neuropathy, uveitis, abducens nerve palsy, cerebral venous sinus thrombosis. I mean, the list goes on. Cerebral acute ischemic stroke and bleeding. So many different ocular manifestations can occur after the vaccine. In our case, to wrap up, we had a 52-year-old female who presented with new onset headaches and bilateral blurry vision. It was 1 week post-COVID vaccine. We did confirm the presence of optic disc edema, and she had relatively preserved visual function. The MRI showed no signs of IIH, but faint bilateral optic nerve sheath enhancements. Serological investigations remained normal. She was treated with steroids and she did recover completely and has remained stable since then. And based on the data from the other case reports as well, patients tend to respond very well to systemic steroid in this case. Thank you.
Excellent presentation, Sheikha.
Thank you.
Again, great presentation and really interesting cases and nice to review the literature. Aaron, I wonder if I could just ask you, one of the things that I was wondering is, when would you lean towards, a course of IV steroids versus oral steroids for treatment of these neurological presumed inflammatory conditions based on the vaccination?
So are you talking about visual loss or yeah? So overall, depends on the visual acuity, how aggressive is it, how rapidly is the vision going bad, is what we, at least what I would decide, depending on what causes it to. So the visual loss in this case was not all that bad. Vision was like 20/25. All that she had was headache. There was clear optic disc edema. So I thought it was okay to keep her on oral prednisone. The vision was very bad if it is 2400 or less, or if the other eye is rapidly deteriorating, I might have considered giving IV steroid. It's a personal preference of neuro-ophthalmologist, really depending on what it is, depending on how aggressive the condition is. If the MRI showed a lot of inflammatory changes, that also may be a reason to consider, IV steroids.
I don't know. I looked at those optic nerves and I said, whoa, that's why I'm asking for your experience when you would try to go with a oral treatment versus a pulsed steroid treatment, IV.
Okay, so there's a couple questions in the chat here. So Safwan's asking, since there's no signs of optic neuropathy on the exam with a normal field and no significant enhancement on the MRI of the optic nerve, can this still be papilledema? And the opening pressure is falsely normal as ICP fluctuates throughout the day? A long question there from Safwan.
Okay, sure. So first of all, this is not IAH. She is on the older side, 53, 125 pounder. She doesn't take any medications. So there's nothing that could trigger intracranial hypertension. MRI showed no signs of intracranial hypertension. LP was done by the neurology team in lateral decubitus position. So the LP was done the right way. Patient does not meet the IAH modified 90 criteria, as Shekhar said, because there was 16 WBCs. There's lymphocytic pleocytosis, which rules out or essentially says this is not idiopathic intracranial hypertension. And the headache, the periorbital pain that she had resolved within a couple of days after starting steroids, which is also less likely to be seen in IAH. The last thing to tell, sometimes patients with papilledema from IAH can have some response to corticosteroids. It's a very controversial thing to use. But if this patient had IAH and if the papilledema, the so-called papilledema, had resolved with the 2 weeks of oral prednisone, steroids are notoriously known to cause rebound papilledema right after we stop it. So this patient would have returned back with, recurrence of optic disc edema, which she did not have. So this is all I could tell. And I've seen this patient now since, July. She has remained stable. As you can see, the very first visit itself, 2-week follow-up, there was improvement in the optic disc edema and the headache had completely resolved. Since then, she's remained completely stable. So far, she hasn't had any symptom at all. Her only concern right now is to have the booster shot or not, as she is terrified with what happened to her. So I don't think this is IAH. No radiological signs. She doesn't have the demographic fit. The CSF is showing cells. And after stopping the prednisone, she hasn't had any rebound optic disc edema, and the response to the prednisone all are pointing to an inflammatory cause. Talking about the MRI, I had to review the MRI with the neuroradiologist, and he does believe that there's something happening there in the optic nerve sheath. The axons are preserved. There's no thickening of the optic nerve. That is likely the reason why the patient did not have much of central visual loss or visual field defect. So even though the disc edema looks so bad, the vision was fairly preserved, and fortunate for the patient that she responded to oral prednisone, and she's been doing well in the last few months.
Excellent. Thank you. Thank you, Dr. Thunderam. One more question. Dr. McGowan asks, is there any experience with the natural history of untreated disease?
Yes, Shekhar, would you be able to show that? We don't know about this one. There's only 5 case reports. Shekhar mentioned 4. There's another case report of bilateral optic neuritis with longitudinally extensive transverse myelite. There's a picture that looked almost like NMO spectrum disorder. All these patients were treated with either oral or IV steroids. Most of them did well, except the most recent case series reported in the Journal of Neuro-Ophthalmology, a patient that presented with no light perception vision in one eye. That eye did not respond at all. So the patient, even after IV steroid, did not do well. So we don't know the follow-up on that. But we don't know if there's a risk for them to have recurrence of optic neuritis with further vaccination in the future or not. But we don't know the follow-up. There's one, that's a slide I just want to show. So as Shekhar had mentioned, vaccine-induced optic neuritis has been in the literature for many years. This is a series of cases between 1971 and 2012. If you look at the right side, case number 4 and 5 was not treated with steroids. And these patients, they ended up having optic atrophy. So there's a likely possibility that if treatment is not initiated on time or the patients are not treated, they may end up sustaining optic nerve damage. So treating with steroids is something that is recommended. I haven't seen any case that's been treated with plasmapheresis or IVIG, except one patient, but that patient had a previous history of multiple sclerosis. Otherwise, none of the COVID vaccine associated optic neuritis were treated with anything higher than steroids.
Okay, I think Ed might have a comment or a question. Ed, you're muted.
Wanted to ask whether the diagnosis of aseptic meningitis was considered here, because this is a patient who was really preserved visual function, and we think of papilledema as the potential culprit in this case, as most of the time. And the optic nerve head and even a little bit of a sheath around it can enhance very faintly in papilledema, and we know that the measurements of the opening pressure can vary throughout the day, and it can be erroneous, etc. And there are a multitude of mechanisms why aseptic meningitis can produce bilateral disc edema.
Sure. There are only 16 cells, and for a patient to have papilledema from aseptic meningitis, at least you would expect to have high protein. And I know CSF pressure can fluctuate like the blood pressure, but it won't if it's such significant degree of optic disc edema suspected to be papilledema. I won't expect it to drop down to 16 when it's done by a neurology resident, especially when the patient is having such active optic disc edema. With the normal protein, only 16 cells, there is a possibility this may be, a lot of patients have aseptic meningitis. We don't know if patients report after COVID vaccine or any vaccine having headaches. Only when we do the lumbar puncture, you come to know. Among the 3 or 4 cases of aseptic meningitis reported after COVID vaccination, the CSF cells, WBC cells, were very high. 16 is a less number with the normal protein. I find that to be less likely to be a causative agent for papilledema. So this proves against papilledema. I don't think so. With normal protein and only 16 cells, less likely. And there's no other leptomeningeal process anywhere else. As Sheikha had mentioned, I reviewed the images with the radiologist. Nowhere else in the brain there's leptomeningeal enhancement to support aseptic meningitis here. I'm treating currently another patient who has aseptic meningitis. She had 110 WBCs with 95% lymphocytic pleocytosis. That patient also had optic disc edema. That's a case I could not discuss here today because of the limited time. But with only 16 cells, a lot of people have 16 cells. So the other patient that SEMA presented, that patient also had 10 WBCs, but there was no papilledema there. And the protein was mildly elevated in that case with almost normal protein. I mean, 245 was this patient's protein and 16 cells. This speaks against aseptic meningitis.
There was a question and comment from Dr. Ng about possibly using steroids to prevent another reaction if a patient like this had a booster. What would your take on that be? If she decides to have a booster, would you pre-treat with steroids?
So the point in giving vaccination is to boost up our immune system to fight the disease. If we pre-medicate with steroids, and if it is going to bring down the immunity, then we might as well not give a vaccination. So I don't know. I don't know if there's any literature there on that. If there is an adverse reaction, autoimmune process, yes, we can treat. There's nothing there. I think it may be worth to just try the vaccination. While looking at the CDC, their recommendation is if there's a serious adverse reaction, which SEMA had listed in one slide, if it is going to be really bad, then in that case, we may have to consider giving another form of vaccination. So the patient who had AstraZeneca vaccination, who had the 6-nerve palsy, he went with the mRNA vaccine and he's done very well. So that is one option, really depending on what it is. So for some reason, AstraZeneca tends to cause Guillain-Barré syndrome more than the mRNA vaccines. mRNA tends to cause myocarditis. Depending on what kind of a complication there comes from the vaccine, we can try to switch from one vaccine to another. That's all we could do. But once the vaccine is given and the patient is having a clear autoimmune process, I think it's worth to try the steroids at that time to prevent worsening of the complication. But pre-medicating, I'm not sure about it. I possibly will take help from allergy immunologists or from ID doctors. So the point of giving the vaccination may not be achieved here.
Aaron, in cornea and high-risk graft or one-eyed patient, I'll follow them a little bit closer. Plus, I often will pre-treat them with a little bit more steroid if they're going for their injection. So it's just different. It's not a hard-clad rule that everybody uses. I think it's something that I do if it's a high risk or a monocular patient. One other question. So we've seen the presumed side effects of the vaccination. Have you seen these neurological conditions occurring in patients who've contracted COVID infection? Are there many reported cases of neuro-ophthalmological problems following COVID infections?
Of course, quite a few. Miller-Fisher syndrome, someone raised it. So Miller-Fisher syndrome has been reported in patients with active COVID infection. As a matter of fact, nearly 85% of patients have antibody, which is positive. It's called GQ1B antibody in Miller-Fisher syndrome in the regular disease. But none of the patients who had COVID that had Miller-Fisher syndrome had the antibody. Guillain-Barré syndrome has been reported. Tolosa-Hunt syndrome has been reported. Dural venous sinus thrombosis. I myself have seen a patient who had a thrombocytopenia, lower extremity DVT, who had a stroke. So multiple complications, and cranial polyneuropathy has also been reported in these cases. So multiple different neurological presentations.
Thank you.
For that question that I had there, Arun, I don't know the answer. I was just doing the Dr. Google, and in the chat box, I have a reference, and they talked about the pretreatment with the steroid not hindering the immunogenicity, but decreasing the reactogenicity. And that was 30 milligrams of prednisone. I think they were healthy volunteers.
Sure.
Okay. I think Jonathan may have a comment or a question.
This is a great case, and we had a similar one recently. In our case, we thought this was more consistent with papilledema and aseptic meningitis, and we actually did not treat the patient, and the patient spontaneously improved. I think in this case, we have a moderate amount of disc edema with preserved visual function. So the differential diagnosis would not include an optic neuropathy, so more like papilledema. So I think in this case, it's reasonable to observe. And asking about steroids, pre-treating, I think in this case, it's totally reasonable to observe. And I would be interested in knowing the patient's color vision at presentation, since there was good visual acuity, a pretty good visual field, and a moderate disc edema. So I would say this could be more consistent with papilledema and could also be observed. Just highlighting the importance of when you have these vaccine related cases, most of them are mild and often leave no sequelae.
Actually, color vision was normal in this patient. As I mentioned, the optic nerves looked fine. It's just enhancement of the optic nerve sheath. Looking at all the case reports, every single one that we saw in the literature, including the ones reported in the Journal of Neuro-Ophthalmology, they were treated with steroids. So that's why I chose to go with the steroids, and I did work. So as one of the slides shown before, we don't know what happens when these kind of patients are observed. Is she going to get worse? The headaches that the patient had were so bad, and there was instant relief to the headache after the patient was started on steroids. The abnormality on the MRI, as I told, even though it was faint, it was clearly there. It is real. So as per the neuroradiologist, that's why I chose to treat. I don't think this is papilledema at all. If this is papilledema, there was a ganglion cell complex dropout too, as she showed on one of the slides. And the disc edema, the way it resolved, and the headache resolving within 2 days was not in keeping with papilledema at all.
And Arun, there were a couple of questions from the audience in the chat box about the GCA. They were curious if it improved afterwards.
Temporal arteritis. There are some case reports of genital arteritis after.
No, sorry. I mean, just the ganglion cell analysis. Did it improve after?
Yes, it did improve. Yes.
Yeah.
Got to be careful with GCA you're talking about, John.
Sure.
Well, another question.
53-year-old, so I didn't suspect GCA in this case.
There's a very practical question from Dr. Gray in the chat here, and it applies to basically the entire panel. Do we have any ophthalmological contraindications to COVID vaccine? This may be something we all see in our clinics with patients requesting this. So I don't know if anyone has a comment there.
From a neuro-ophthalmic perspective, Guillain-Barré syndrome could be one, but if it is a simple cranial neuropathy, I would take the chance of giving the booster vaccination with close observation. From the ophthalmologist side, I will leave it to the panelists. If anybody wants to comment.
From an anterior segment perspective, I agree with you, Aaron. I don't think I would caution against getting vaccinated. I would just maybe watch them a little bit more carefully, especially, as I said earlier, if it's a one-eyed patient or a high-risk patient, a high-risk graft, for example.
So we're getting close to time, and I just have a few announcements to make. First of all, congratulations to our presenters and Dr. Sundaram for a very interesting rounds and one of our most highly attended rounds to date. So thank you very much, all of you. Great presentations and great discussions. I want to everybody.
John, I wonder before the announcement, I just wanted to say those are really good rounds. Thank you. Very interesting cases and really good discussion and great presentations by Sheikha and Seema. Thank you very much.
Thank you very much.
Did y'all put water on me and dip hand in the water and put it on me?
I think we've got little boys coming in from the background there. So next week, want to send a reminder that Dr. Nupur Bakshi has arranged a special EDI grand rounds on Indigenous health concepts. We have the speaker, Dr. Chase McMurran, who's an Indigenous leader and physician here at UofT. So look forward to hearing that. Hope you all can attend and we'll spread the word. Just a few other short announcements. There was some interesting accomplishments of our faculty on ONT-I, and not all the residents, I don't think any residents have access to ONT-I, and some of you may not know. So I just want to call out, first of all, congratulate Dr. Rajiv Mooney for winning the inaugural ARVO Kreisig Award or Kreisig Award for innovations in retinal surgery. This award was given for his clinical insights into the long-term clinical outcomes in retinal detachment repair. And many of you have seen some of his talks on the excellent work he's been doing on that. Dr. Rosa Bragamele has been honored to give the 2022 Binkhorst Lecture at Ascaris. This will occur on Saturday morning in the opening session of Ascaris. And she will be speaking on her journey in ophthalmology, including innovation, education, mentorship, and balance. And then also here we have Dr. Edsel Ng as part of the panelists this morning, and he has written a book on medical education, which is available both as a free EPUB as well as for a small cost in a better format. And he's done this for hoping to benefit local food banks. So congratulations to all of those faculty as well. And thank you once again to our presenters and Dr. Sundaram for great rounds today. And we'll see you next week for the EDI rounds.
Thank you all.